Robin Vanderpool will be introducing Dr. Heather Brandt in just a second, but before that happens, I would like to tell you about a few happenings around the College of Public Health. As many of you know, I'm Nancy Schoenberg. I'm the Associate Dean for Research here at the College of Public Health. And as always, we've got a lot of great upcoming events for you. The Lunch and Learn that will be happening this coming Thursday, or next Thursday, a week from today, March 3rd, from 11 to noon, will be on preparing presentations. Dr. Sabrina Brown and Lori Chestnut from the College of Public Health will be talking about preparing fantastic presentations. And in just a second, I'll tell you why that's so important. But now know that we selected these two individuals because they are terrific presenters, and you'll learn a lot from them. Even people who've done a lot of presentations will learn a lot from these two terrific presentations. The reason, among others, that you should sort of buff up your presentation skills is because on April 21st, the Center for Clinical and Translational Sciences has their annual conference in the Convention Center, the Downtown Convention Center. That is a conference that we would like every single one of you, students, faculty, to submit an abstract for and then eventually present. Our own Emily Dressler is your liaison from the College of Public Health, and she would like us to turn out in huge numbers. The College of Public Health is one of 5 or 6 colleges that is represented on that day. And we have had a modest visibility in that meeting in the past. Some of our students have presented and done some great things, and we would like a huge participation rate for that conference. So please see Emily, please see me, or Margaret, or Jen, other people who are involved with the CCTS meeting, April 21st. Mark it on your calendar. Even if you don't have a capstone or something else to present, it's a great conference, and there's free food. It's like unlimited, huge quantities of really decent food. So and it's free. You should register for that meeting. I would like to announce a couple of just-in-time awards that we have just. What are just-in-time awards? Just-in-time awards are small pots of money that you can apply for. Students, faculty, we're all eligible to apply for these awards. They are designed to give you a little bit of money to do just a few things. You are encouraged to apply for the award if you are using it for pilot data, to submit a grant, or to finish up a manuscript. They are not meant for little research projects, terminal research projects. They're not meant for that. They're meant for the next step, to prepare you for the next step, which is applying for a grant, or applying for, or writing a manuscript or a presentation. They're not designed to just let you do a little study. That's not the intention. But if you would like to, we still have a little bit of money left. You may apply for a just-in-time. You'll see that on the website. Angel Algarin and Nate Wilson have just received just-in-time awards for their 2 projects. And those are terrific projects, so please consider that. We also, faculty members from the College of Public Health, are eligible to apply for our pilot award. That goes until applications are due March 1st. The award of $10,000. We have a number of additional fantastic events that are upcoming. We have got the Research Design Case Competition on April 7th. That will be a really fantastic event. And and we've got our Meet the New Faculty presentation on Thursday, March the 31st. So those are some really terrific events that are coming up in the College of Public Health. So now I'd like to turn it over to Dr. Robin Vanderpool, who will introduce our distinguished lecturer, Dr. Brandt.
Thank you for the opportunity to formally introduce Dr. Brandt, and thank you all for your attendance today. We're really pleased with the turnout, especially with the threat of another blast of cold weather that we had today. Dr. Brandt and I have formerly been on study sections together, and then more recently we're getting to work together more collaboratively through our funding in the Cancer Prevention and Control Research Network. We are co-leading an HPV vaccination work group, and then we've also been active with our respective cancer centers in their work around HPV vaccination. Heather and I both applied for a travel award from the Southeastern Conference. Yes, the SEC does more than sports. We can travel. Faculty can apply for funding to travel, and we had the kind of brainstorm idea for Heather to apply to South Carolina to come to Kentucky, and then I applied here at UK, and I'm going to Columbia in March to do a very similar presentation where we can work on research projects together, but then also present to our colleagues and students. And so after this, Heather's actually going to go visit with our capstone class in the Department of Health Behavior with our students. So I think it's a win-win for both of us. So to get all those kind of more anecdotal stories out of the way, Dr. Brandt is an associate professor, and you can read this here on her slides, but at the University of South Carolina in the Arnold School of Public Health. She's also a faculty member in the Cancer Prevention and Control program there at USC. If I had brought her resume and her CV, we'd still be reading accolades at noon when this is over. But what I will highlight is that she won the Early Career Award from the American Public Health Association. She has won numerous teaching awards at the University of South Carolina. And I think what is probably very meaningful to Heather is she's also won numerous service and research awards from her community partners in South Carolina for the great work that she does around women's health and cancer health disparities. And so with that, I'm going to turn it over. If anybody is on Twitter right now, you can follow Heather at Blonde Scientist. That's her handle on Twitter, and she's always tweeting out cervical cancer information, HPV vaccination, and all kinds of other health topics as well. And with that, I think just one other side note, Heather and I were talking yesterday. You know, it's always nice when you have good research colleagues that you admire their work, you admire the things they do in the community and in the classroom, but then when you also get to call them a friend, I think that means a lot too. So with that, I'll turn it over to my friend, Dr. Heather Brandt.
Thank you. Thank you very much, Dr. Vanderpool. Thank you. And thank you, Dr. Schoenberg. It's nice to see some friendly faces in the audience, some I haven't seen for a while, and then a lot of new faces. So thank you for coming today for this lecture. I'm really excited to talk to you today about the work that we've been doing related to partnered and engaged approaches to address cancer-related health disparities. It's really a passion of mine to work with others to achieve positive outcomes and realize and see impact. And so if you're in the field of public health and you thought you wouldn't work with the public, you've been sadly misled. That group project that you had to do and you thought, I hate working with people, it's just not how public health gets done. And of course there are good partners, there are not so good partners, and some we have to carry along with us. But public health really is a partnered research discipline. And so I view my research and my contributions through that lens of being able to achieve more and accomplish more by working with partners. And I'm sure that when I say Dr. Gil Friedell's name, that rings a bell to y'all. So I've heard Dr. Friedell give several talks, and one of my favorite quotes of his that he says, if the problems are in the community, then so are the solutions. And so we can take that to mean that if the public health challenges that are facing us are known to partners, known to community members, then that's where we as public health professionals, medical professionals, people who are interested in health, have to go to get to those solutions and get to outcomes. So the first part of my presentation, I'm going to summarize some of the connectivity between health disparities and partnered approaches. And then if I have time, I hope I do, I hope I've timed this correctly, I'll be able to share with you 3 different examples of our partnered research that has some unique features and characteristics that may be of interest to you. So no surprise to anyone here, nothing new, but important to keep on the front of our minds here when we're thinking about addressing public health problems or health threats in our communities, that health disparities don't occur related to a single factor. They're not the cause. The etiology of the disparities that we see between racial and ethnic minority groups, rural and urban populations, people who have higher SES and low SES, don't happen because of a single factor. If they did, I'd like to think in such an industrious country like the US and with scientists across the world and researchers and really smart people, we would have been able to solve that. But these differences happen across multiple levels. They manifest themselves in multiple ways. They're interwoven and complex. I like to think of health disparities sort of as the spider web, and how the web continues to strengthen. Even when you break part of the web, it can continue to perpetuate. And that's one of the reasons why addressing health disparities are so challenging. In South Carolina, similar to here in Kentucky, we have a lot of disparities between different groups. Last night at dinner, I heard about some of the work that Dr. Stutz is doing related to lung cancer screening and others involved with that work, because lung cancer is a serious issue here at the state of Kentucky. And in South Carolina, we have similar disparities, differences in health threats, and those are all very interwoven and complex. And so, while there's been great progress, you perhaps have seen the headlines. Colorectal cancer mortality has declined. But look behind the lines. Those declines haven't been beneficial to everyone. We still see higher and increasing mortality among racial and ethnic minorities, for example. We've really failed in a lot of ways in translating what we know works into the hands of those who can use it. And so if we're going to have population level impact, make a difference in public health, we have to think about addressing this void, this gap that occurs. And someone I learned a lot from was Dr. Harold Freeman, who was a breast cancer surgeon in Harlem, and he actually is the developer, or one of the most well-known developers, of the concept of patient navigation. And Dr. Freeman also developed something called the discovery-delivery disconnect. And this continues to very much hold true to me when I think about where the divide happens. We invest so much on this side over here, the research enterprise. A lot of time, energy, resources, effort built in over here. And then there's this divide. There's this disconnect in getting what we know works into the hands of people who can put that to work for improved health outcomes. So figuring out how to address or bridge that divide is one of the challenges that faces us. And it very much is aligned with the challenges we see in health disparities. Because for some groups, there's no divide. For some groups, this works seamlessly, from this side all the way over to improved cancer care for all. But that's certainly not the same for everyone. And this is an adaptation that is a synthesis of Dr. Freeman's model with the National Cancer Institute model. And one of the approaches to partnered and engaged work that I use is called Community-Based Participatory Research, or CBPR. I'm sure you've perhaps heard of that term, or familiar with that. And usually partnered approaches, or approaches that engage stakeholders or community members, generally happen over on this end of the continuum. They don't happen throughout. And so with my mentor and other colleagues over the last several years, we've developed this, which looks a little messy, but it's much simpler, I promise, this recurring loop idea, where if we're able to get community members and get partners engaged throughout that entire continuum, we have a better chance of achieving delivery and dissemination outcomes that reflect the context, the real lives of the people who can benefit, whether that be in a medical or clinical setting, whether that be at the local health department, whether that be at a church or community organization, that we can, by investing early on in that continuum, have a tremendous impact on the backside there and achieve better outcomes that are more equivalent for everyone. This is from the AHRQ evidence report on community-based participatory research. Again, just one approach to being able to work with partners, work with engaged individuals on joint research efforts. This is available online publicly. You can find this model. But I do it to show some of the differences between how traditional research is conceived and the opportunities that are presented when using community-based participatory research approaches, or when just working with partners, listening to partners, going to where the problems are to listen and learn about where potential solutions lie. In my work over the years in South Carolina, I've been doing public health work there for 19 years. And I still work with some of the same partners I met in the first 2 weeks that I was in South Carolina. We're a small state, and we still have to work collaboratively to overcome barriers that exist, not unlike many of the barriers that you face here in the state of Kentucky. Public health is pretty universally underfunded. But by working with communities and working with partners, we can strengthen the design of our research approaches and methodology to ensure that there's contextual validity throughout the process. To ensure that when we end up with that intervention that is shown to improve BMI by 0.24, significant at a p-value of less than 0.001, that it matters, that what got to that point is valid and real and can continue in the community. It can be replicated, it can be spread. By doing that, we have the chance to reduce that disconnect and reduce that gap. And there are a lot of points along the research continuum where partners can jump in and partners can be a part of the efforts. So there's a strong rationale for partnered approaches, and I think that the complexity of the health problems facing the public currently, especially certain groups in our communities, they're really ill-suited to that outside expert. So I have to work with partners if I'm going to effectively address the health issue at hand. And I think I conceptualize this as the fact that we may know the number and data, we know the statistics, but they know the face of their neighbor, who they loved and who they had coffee with. And that's real, and that's meaningful, and that's powerful. And that person brings something to the table that is important to the work that we do. There's, of course, been for many years increasing interest in health disparities. There's been disappointing results in interventions. Interventions may have achieved statistically significant results in some way, shape, or form. But what does that mean in the end? Are we really making a difference? Are we really able to overcome that development to delivery and dissemination gap? There's increasing demand when working with communities and working with partners for collaborative approaches. So no longer accepting community-placed research. So I remember years ago when I was at a research meeting at the University of South Carolina, where a very respected colleague stood up and said he did community-engaged research. And I thought, well, that's interesting. I didn't realize that he engaged in that type of research. And so I was listening very intently. He said, we take our surveys to people in the community and they fill them out. And there's a difference there because those communities and partners who are part of that, they've been raped of their data, for a lack of a better analogy. And so that perpetuates mistrust and distrust in communities that already are skeptical, that have been deprived and historically had information and resources withheld from them. I think that you can consider how frustrating that must be. And then to characterize the research in such a way. And so had a very interesting conversation with him afterwards, and we agreed to disagree. But that conceptualization there is just something that people who are doing partnered and engaged work have to then overcome. You're sort of working around some of that. But there's a lot of interest in these approaches. There's also been increased funder interest. When we do our research, we need resources, we need funding. And so having that available to help support that. And thinking about how stakeholders can drive research questions. And I'll share an example of where that happened and how I was the skeptic on the back end. A lot of benefits, I won't go through this entire list. We could spend a long time discussing the benefits of partnered or engaged approaches to research. The one that's most salient to me is that this type of research has the potential, when done well, to overcome that disconnect, to really ensure that when we're generating evidence, that evidence reflects everyone. That evidence reflects the people who will ultimately have the opportunity to participate in the intervention or the program or receive the various treatment or care. Lots of historical examples about how that wasn't the case. And that one is most salient to me. And then the second one up here that's also most salient to me is the ability to increase individual and partner capacity. So leaving the partnership, leaving the community better off than when you arrived. And so making investments in that capacity. And I'll share an example about some work we're doing related to that. Now, this type of work is not without challenges. I meant to ask before I showed the benefit slide, how many of you have ever worked with partners on a research project? Okay, a large number of you. So you're also probably quite familiar with the challenges that are associated with this kind of work. In South Carolina, it's not a mistake that I've got politics up in the front. So right now in South Carolina, we have two senators, Senator Fair and Senator Bright, who have been blocking a cervical cancer prevention act that would allow for access to HPV vaccination to prevent cancer. And so we say it's not fair, nor is it right, that this continues to be opposed. And so politics plays a big role in the work that we do. In states that have not expanded Medicaid, figuring out workarounds. In our state, which has not expanded Medicaid, our governor supported our own program. Because in South Carolina, we can do it better than y'all. So, right, that's the thinking. So our governor prepared and implemented our own version of expanded Medicaid, which after 18 months has entirely collapsed and caused a lot of challenges. It provided care for 400,000 additional people for about 1 month before it imploded. So politics is front and center in a lot of the public health work. I don't know why cancer prevention is political. It's unclear to me why that's the case, but it is. And a lot of the work we do in cancer is political. And then we have a lot of other barriers, and competing interests and time demands really factor into this type of work. There's just no way to avoid those. And so being sensitive to those issues helps to overcome these types of challenges. And the last one I'll point out here is that life happens. And I think about how crazy my own life has been for the last couple of weeks, and it just happens. And so trying to uphold your end of the bargain and being transparent in that is very important when doing this type of work. So I think there are some essential components. These are informed by the work of Meredith Minkler, Nina Wallerstein, Marcy Campbell, and others who've been doing this type of work. I think there are a lot of essential elements. These are the ones that resonate most strongly with me in the work that we've done. And the one that I want to point out here as being really important among all of these is the everything on the table approach. Being incredibly transparent. And that's very challenging for some people. I mean, sharing financial information, sharing information about deliverables, allowing partners to interact with the CDC program officer, with the NIH or NCI program officer. There's a lot of perceived risk. We'll talk about the health belief model for a second. A lot of perceived risk with doing that. But yet it's important to demonstrate that you're working together collaboratively, keeping things all on the table, and being incredibly transparent. I think the contextual validity of this type of work as we develop programs or interventions becomes really important in order to make sure that what you end up with is something that can last. Because most often what happens with these types of efforts, once the funding goes away, what happens to the program? It goes away. Your chances of sustainability are enhanced and increased when you're doing it with a partner. I'm not going to share this example today, but we had a community-style navigation program that we were doing with a hospital. So it's not patient, but community-style. And after the funding went away, they put it as a line item in their budget because they saw the value of what that work looked like. And so I think there's a lot to be said about partnered and engaged approaches. So the first example I'm going to share with you is a Community Networks program. And Dr. Mark Dignan has had one of these grants here at the University of Kentucky and done a lot of work through this mechanism. And in South Carolina, we also have one of these. And I've been the director of the Community Corps since the initiation of the grant and since we submitted it in 2004 and it was funded in 2005. So the Community Corps is really focused on working with partners to address cancer-related health disparities in the African American community in South Carolina. I'm using that term African American community very broadly and diversely, just referring to the group that we're working with here, not that everyone is the same. And this church here is a very historic church. It's on Washington Street in Columbia, South Carolina. It's Zion Baptist Church. It was a real heart of the civil rights movement in South Carolina. And it's one of the main places where we started doing this work with the church. They had a very involved health ministry at the time. And so our partnership has been with African American Baptist churches. The state of South Carolina has about 4.5, 4.6 million people, and about 30% of those are African American or identify as Black or African American. So it's about 1.5 million. Of that 1.5 million, about a third are members of this denomination. So it is the largest and oldest African American denomination in the state. Perhaps through the unfortunate and tragic events that happened in June in Charleston, South Carolina with Mother Emanuel, which is one of the AME or African Methodist Episcopal churches, that's a different sect. Also a very large one, but not as large as the African American Baptist churches. They have about 1,500 churches across the state. Now those tildes there are very intentional because in the Baptist Convention, if you don't pay your dues or you're behind in submitting reports, you come off and on the official register. So when you ask for the official count, that's generally what they say. And the same is true for the number of members as well. So unlike the AME churches, the African American Baptist churches had no formalized health ministry. In the AME churches in the 7th Episcopal District that covers South Carolina, they had a very well formalized health ministry plan. Health ministry directors, programs, services, resources, well-oiled machine. That was just not the case in the Baptist churches. And so we initially started working with the larger convention, and we were really having trouble making headway going forward with them. And that's when somebody said, well, quit working with the men of the church. You need to start working with the women. And so we thought about it and we talked it over with some of the community partners and leaders who we were working with of other organizations, and they agreed. And so while the men who serve in the role of pastors, because if you're going to do anything in churches, you have to have the blessing of the leader, and in Baptist churches, that's the pastor, all of whom are male. But all of those pastors, or almost all of those pastors, are married and have a wife who's the first lady of the church. Also very influential. Also very interested in health issues. And so through the Young Women's Auxiliary of the women's part of the convention, where the First Lady is in charge of that, they started this process of establishing a health ministry. We were observers at this point. So we were just hanging out on the sideline, providing information when requested. We need some data on breast and cervical cancer in African American women. We provide it. How do you want us to provide it? Do you want us to use pie charts, graphs? Do you want numbers? What do you want it to look like? And we provided that. And in 2002, Dr. Williams, who is actually AME, but has been working with the Baptist churches for a long time, presented at their annual meeting, presented on the state of health disparities in African Americans. And that resulted in an immediate motion to implement and enact a health ministry. And things don't happen real fast in churches a lot. You know, some partnerships, things just don't move real fast. And that's generally very true in faith-based settings. And within a year, they already had a plan approved to move forward. There was a lot of momentum and a lot of interest. And about 2 months after this, we had our first research grant working with them. And what was it on? Prostate cancer in African American men. And so they were very excited to get started. They developed a strategic plan, a vision statement, a mission statement, really forward thinking, focused on the lifespan. There's nothing specific in here about cancer, but that was just their primary interest, but they wanted to think more broadly. Because this group of very well-informed advocates in the church understood that if we can get people eating healthy foods and get people active, that's going to have an impact on a number of different chronic conditions, acute and chronic conditions. So they really focused on the lifespan and larger prevention issues. They also developed formal goals. They have about a 13 or 14-page formal plan that they continually update as they're making progress. They're also thinking about the whole person, so spiritual health as well as physical health, not compartmentalizing those and viewing those as mutually dependent on one another. And they're very well organized. They had existing infrastructure that we, again, sat on the sidelines and watched them develop, watched them implement this, providing and facilitating when needed. So South Carolina has 46 counties, and they have broken those into 8 health ministry regions. Each region has a regional coordinator. Each county has a county coordinator, and the active churches within the county and association have a coordinator too. So there's multiple levels of infrastructure that have been developed. And that's how they've had the ability to so expeditiously implement programs. They started on their own accord. Again, this is their interest, was called MESS, Mothers Eliminating Secondhand Smoke. It was to get the churches to become smoke-free. And within about 6 months, they had almost 3/4 of the churches having signed agreements and policies that hung in their church. And again, we watched them do that. That was important and of interest to them and provided support, while we were working on a number of other initiatives, including the Witness Project, which you may be familiar with, an evidence-based breast and cervical cancer screening program. We had developed the prostate cancer screening program with them as their first federal research grant that they were a subcontractor of. And then the Cancer Health Disparities Program, which I'm going to tell you a little bit more about. We also continue to provide church bulletin messages. So they are in Microsoft Word format, so they can be plugged into the bulletin, or they're made to be copied and inserted into the bulletin. We distribute somewhere between 10 and 12,000 of those every month to be distributed. We usually try to align the content with various recognition months. So next month is March, which is Colorectal Cancer Awareness Month. So we'll do something on colorectal cancer. We've done a number of cervical cancer and HPV programs and such with them. And then we've developed this guide. It's a training and technical assistance guide called the Red Notebook. And it's a resource for all different types of cancer. And we include this current data, current information, with links and phone numbers to be able to call to get updated information. So we've directed them to establish an existing resources so that we're trying to make that longer term investment. So this Cancer Health Disparities Program is one of the great lessons I've learned in the time I've been doing this work. I thought it was a horrible idea. I thought, people know that health disparities exist. We don't need to tell anyone that African American women are less likely to be diagnosed with breast cancer, but twice as likely to die of breast cancer in South Carolina. Like, they may not know that statistic, but people know that. And I listened. It took almost a year, but back and forth we went, and they wanted to develop this program that not only featured the magnitude of the differences, but that would start at the very beginning with how cancer starts. How and why does someone get cancer, based on what we know today? So they wanted to include basic biology in this presentation that's going to be delivered by lay health advocates, some of whom may have a health or medical background, but most of whom are just really interested in the health of the people in their church and want to do this work as part of living their mission. And I was very skeptical. I thought it was a horrible idea. I thought they were crazy. But then I watched it evolve. I watched and listened to how the partners continued to talk and ask around and bring other stakeholders to the table. And so in 2009 is when we started to develop this program. And it really came at the request of some of the pastors and first ladies and other members of the YWA regional coordinators who were so interested in themselves having a deeper understanding and thought that that would be important for the community. They packed out these sessions. We would have 30 chairs, there'd be 50 people. There'd be people sitting 2 to a chair, standing in the back, and paying attention to these biology slides. I mean, talking about how normal cells turn into cancer cells when exposed to carcinogens. Those are things that can cause cancer, and talking through all of these basic processes, then talking about what you can do about it. So incorporating cancer prevention messages, incorporating cancer screening recommendations, addressing myths and misconceptions that are very strong and alive and well in the faith community and in many communities. And then providing information on where people can go to get more information. And so after all of this time of developing it, we started training lay health advisors to implement this program, preparing them to work in teams so that no single lay health advisor would be responsible for the entire program. Because some people really liked the cells and biology part, and some people that really scared them. They were unsure and lacked confidence in their ability to deliver. So they talked about some of the other pieces. So I've inserted here just a few of the slides. This presentation was available in PowerPoint form, but also on large flip charts. So it could be given anywhere. And then we had placemats and handouts that could be used to help facilitate and start conversation and dialogue about this. And we provided the PowerPoint, the netbooks, all of that type of information to the different regions and then counties within those regions where we addressed. There was a script, a facilitator script, a lot of practice, a lot of role playing, technical assistance provided, mostly just to help people get facts straight, but to tell their own story about it. A lot of people told their personal stories about their relationships to these different types of cancers. This one here is on preventing cancer, just different recommendations for preventing cancer. Cancer screening, we run through all of the latest recommendations. We talk about some of the pros and cons for making different decisions, particularly related to prostate cancer, which continues to be a very important issue in the African American community. In South Carolina, African American men have the highest rate of prostate cancer in the world. So try going into that community and telling them that the United States Preventive Services Task Force no longer recommends screening. It's just not the best message to do this. Addressing myths. One of the biggest changes we saw from pre to post test, we have about 5,000 to 6,000 people who've taken part in this program, and one of the biggest shifts we've seen is in fatalistic beliefs, and believing that, wow, now that there really are some things that maybe I can do to try to address my risk for cancer. And we've included these, which were all the prominent myths that came from our formative work with the churches. This is something else that came out of our work. This is called an illustrated map. My colleague, Dr. John Urita, is the member of our team with this background and expertise. And so this map is designed to start conversations about cancer. And there's no right or wrong way to read this map or look at this map. The highway is called the Long Life Highway, and even if you get off the highway at different points, you can still get back on the highway. And there's lots of different points at which you can engage in reducing your risk through your lifestyle, or engaging in screening activities or vaccination, getting treatment, adhering to treatment and surveillance and such. And things that matter to people, why this all matters. And so this is served as a tool for the program. We have a YouTube video and a training for our lay health advisors. Some choose to use the PowerPoint and the map. Some choose to only use the map and have conversations about the different pieces. We have a prevention map also, which is just the top right-hand corner, the screening map, and then we have a map about the outcomes. So we use this as a vehicle or a tool to really start conversations about cancer-related health disparities and providing people with the opportunity to share their stories and then integrating information about messages, about getting screened, about making vaccination choices, about following up on abnormal results, and being real about the things that matter: family, their faith, their community, and thinking about what they value as part of this process. So that's one example of how we've worked with partners to come up with different innovative approaches of delivering information, really listening to our partners on what they wanted. In spite of my skepticism, I'm a huge champion for the program, and really work hard to help continue to support the implementation. This is the full map again. Another project I want to tell you about that's called Didactic is a dissemination and implementation grant of a diet and physical activity intervention. I'm not a diet and physical activity researcher, so don't ask me any questions about diet and physical activity, but I'm interested in it because of the partnership components. So there was a randomized controlled trial that was conducted that resulted in this intervention being designated as evidence-based. It's called HEALS, Healthy Eating and Active Living in the Spirit. And then the idea was, now let's get this intervention into the hands of churches where they can use it, they can adapt it, they can continue it, sustain this work, we can reach out to more churches and such. And as part of this, we included a specific aim that was related to the investment in the capacity of our partners. And so that's where the Leadership Development Grant Writing Series came. So aim number 4 of our grant is to focus on the capacity of the churches and the leaders within the churches and the surrounding community. And we have advisory boards, we have councils, and we have members from the community who attend all of our team meetings and such to help guide us in this process. And the goal of this grant writing series is to enhance the capacity of our partners to be able to sustain initiatives, find small sponsorships, find donors, apply for small grants if they wish, figure out how they can use the church budget to be able to incorporate some of the activities that they want to sustain and continue. And so we've framed this in the context of a grant, but it's much larger than that. It's thinking about the resources that are needed to sustain and continue the program. Let's see. Do this. the overall objectives of the grant writing series are really very broad and focused on making sure that the members who participate understand the importance of looking at their organization or church from the inside out, thinking about partners and collaborators if they're missing expertise in some area, and figuring out how to find opportunities and pursue those opportunities. And for the participants, we're trying to help increase their understanding of the process and further develop their skills. So we use didactic and very experiential exercises during the course of these sessions, which are led by volunteer experts from nonprofit and other organizations in the local community who come and dedicate and donate their time for this. And our goal is to try to get all of these participants to actually submit an application in the next 6 to 12 months. And while it says grant application, we also are encouraging them to identify sponsors or seek other forms of support. So the grant writing series included 5 different sessions, preparing for submission from the inside out, focusing on doing an internal assessment of what are the strengths that you have already in your organization and where do you need some help, working with partners, finding funding opportunities, actually writing the grant proposal. That was a very hands-on training where the members broke into teams and actually wrote goals, wrote objectives, talked about what story they wanted to tell about their organization and why it was important. And then making the cut included a panel of 4 local funders who came and kind of told some of the secrets of the trade about what to be thinking about when pursuing grants and opportunities. And so these investments, we were at capacity. We could have 33 enrolled. We had 33 in a long waiting list. And the commitment was to come to all 5 of the sessions. And as part of the experience, participants were able to write and submit sample applications, which were reviewed by 8 people with all of the comments given back to them in a one-on-one meeting to provide constructive feedback for ways that they could improve or what they could tell as part of the grant application in the future. So it was very hands-on in that way. And we tried to make it practical and real, and so we had a number of the participants take advantage of that. We also asked them to enroll in teams, thinking about who they might collaborate with in their own organization or community going forward. And the last one I'll share with you in just the next few minutes is the newest of the projects. And it's really a culmination of having long-standing relationships with a number of partners in the state of South Carolina. This is the colorectal cancer screening program in South Carolina, funded by the CDC. Y'all also have one of these here in Kentucky too. The focus is on implementing priority evidence-based approaches to increase colorectal cancer screening. And so very quickly with our partners, because we had so many partners in place, we were able to just start focusing on these deliverables. We have partners who we've worked with for a very, very long time, and we were able to jump right in because we already had those existing relationships, and we're able to start getting to the point where we're going to be implementing these priority evidence-based strategies. So we started setting up regular meetings. We have an evaluation team. We work with our CDC program consultant. We work side by side with the American Cancer Society, which in South Carolina has a very well-organized system of regional service coordinators and primary care staff who are already working on the federal breast and cervical cancer program in our state and are also working on colorectal cancer. We work with the Center for Colon Cancer Research colonoscopy screening program that exists, and with our Primary Healthcare Association, our PCA in South Carolina. And all of that progress was based on the fact that we had these established partnerships for a very long time, and were able to quickly come together, recognize the opportunity, and move forward. We have a flow chart that guides our activities across the process, these 3 phases, where we are focusing on partnerships and selecting sites, collecting the required baseline data, and then our plan for implementation. This is all done with partners. So it's conceived with partners and it's being implemented with partners, including our evaluation activities. We have an advisory council, we also have an evaluation committee, all with representation from our partners. So in the interest of time, I'll share these slides with Dr. Vanderpool should you be interested in reviewing them later. I want to end on a couple of points, one being our assessment of readiness. So over time, one of the biggest factors that we feel determines whether or not you're going to be able to have a successful intervention or work well together is how ready your partner is. And I'm fortunate to be at the University of South Carolina where Dr. A. Wandersman and other colleagues have been developing this framework. It's a formula. It's called R equals MC squared. So R stands for readiness. The M stands for motivation, and there are multiple characteristics of motivation. And the C2 stands for 2 types of capacity. Basic general capacity of the partner or organization, and then intervention-specific or topic-specific capacity. So it's a really nice framework that's guiding our selection process here. And it's becoming a permanent approach of how we're identifying partners, how we're going back to partners to find out if they're interested and ready to work with us to try to be able to increase the success of our efforts and maximize the investment. I've included kind of the progress we've made in just a very short time. Again, I'll share these with Dr. Vanderpool if you're interested. So to end before questions, just a few take-home points. I'm very committed to using partnered and engaged approaches. I think it's the best way that we're able to overcome that discovery-delivery disconnect and really make a difference in health disparities, particularly those in cancer-related health disparities, which is where I focus most of my time, energy, and effort. And I think if you're really, truly willing to listen, have a willingness to listen, as I did with the cancer health disparities example, when it came from the community, really massaging that idea and working together, I think being willing to listen is an incredible part of working with partners and with engaged approaches. Being able and willing to share power and maintain transparency about those power differences, not a main focus of my talk today, but certainly a very important element of doing partnered and engaged research approaches. Trust is earned and it takes a long time, and if you lose trust, good luck. You really have to make sure that once you've reached that point of trust that you're able to keep that, cultivate that, nurture that, sending birthday cards, sending holiday cards, acknowledging deaths of loved ones, going to funerals, really maintaining that connectivity and demonstrating that genuineness of the importance of the relationship that you've established really underpins the trust. It's a slow process and may not be for everyone. If you want results by the end of next week, it's maybe not the best method for you. It is a slow process, but I also find it to be incredibly rewarding. I love it when I'm out at Target or somewhere and somebody who I haven't seen in a while comes running down the aisle. It's just a great feeling to have the chance to reconnect with people who you touched in some way and your work with partners touched them in some way. Really focusing on that clash. Community culture is very different. Partner culture is very different. Organizational culture is very different from academic culture. And there's differences across organization type and across partner type as well. And really making sure you're managing and balancing that process. I'm not a patient person by nature, but in doing this type of work, I've really had to demonstrate a lot of patience and being willing to let things play out and making sure that I'm just continuing to be engaged and do the little things that are going to matter in the end in a big way. And being culturally humble and having cultural humility. I'm a white girl from Iowa originally. And I've been working in the African American faith community in South Carolina very successfully for a very long time, because I don't pretend to be something that I'm not. And I don't pretend or portray false pretense in that way, and really appreciate and value the lived experience and the daily realities of my partners, especially the work I've done in the faith community. Because I revert back to this statement where I may know all of the data, statistics, or be able to direct you to important resources, but you know that Miss Joanne, one of our lay health advisors, who worked with us from the beginning of the Cancer Health Disparities Project, they know that Miss Joanne sat in the third pew on the right side every Sunday for almost her entire life, and she lost her battle to breast cancer. And that's what they know, and that's real to me, that's meaningful, and that's powerful, and that's how partnerships can really help us on a larger scale achieve more equity and really address cancer health disparities. So thank you very much for having me today.
We have a few minutes before noon if there's any questions in the audience.
Hi. So from what it sounds like, you had a pretty smooth process in terms of like getting on board with the faith-based community and implementation. I'm wondering if you experienced any type of like resistance or hesitation once you got with the women's group. And if so, how did you kind of combat that to make sure that they were receiving that information? Like, hey, we need to go ahead and move forward with this process.
So we were really fortunate to have some pretty prominent women on our side in the Baptist Convention, and that really made a huge difference. They really went to the male leadership and advocated for this health ministry, advocated for these programs with no restrictions. I've given presentations on HPV where I've projected a cervix on the altar. I mean, they've just been really open to this. They're really interested in health. So they kind of gave it this, our people are dying. That's what I hear. I hear that our people are dying. Our loved ones, our neighbors, our community is suffering. It's time to not let those barriers or restrictions that we may perceive or may be real. Let's do what we can with what we have. And that's really how they moved forward. Did they run into conflict or run into brick walls from time to time? Sure. But they were the experts on that side, and so we provided the support we could, and they obviously were quite successful in moving forward.
Anyone else?
The grant writing sessions that you did, I really liked that, and it was really novel. Can you give us an update on how that's going and how much funding they've received and
Sure.
how much feedback they've gotten so far?
So our last session was February 6th. So that was the making the cut with the panel of funders. So we just actually completed the overall post-test with our participants. So now in 6 months, we're going to check in with them, and we're going to check in another year after that. We are going to run it again because we had such a waiting list, and then people would show up with their friends. And it was just a lot of interest in getting that type of information. And then I think after the first couple of sessions, people really liked it. And so then more people would show up. And so we've already started making plans to offer that again and figure out how we can improve based on the feedback we received.
Thank you so much for such a wonderful presentation.
Thank you.
I wanted to ask about your suggestions for community-engaged research in communities that don't have as well-established community-based institutions. And I think one of the things that's really exciting about your work is you're able to build on this incredible infrastructure and provide resources. But I'm sure also you know about and have done research in communities where there's simply it's not the same level of organization, nor if there are community-based organizations, they aren't as representative. So I'm wondering if you could talk a little bit about that.
Thanks. That's a really good question and an important point to note that in many communities there aren't these structures or these leaders or gatekeepers who exist, but there's always natural helpers. And so it's figuring out who are those natural helpers. I saw Aaron Guest sneak in the back there. He's a doctoral student in gerontology here, but he's from South Carolina, went to school there before. And Aaron and I worked on a project with Dr. Darcy Friedman and some in Orangeburg. And in Orangeburg, South Carolina, there's a lot going on, but it's very disjointed and disorganized, for lack of a better way to sort of describe it. And those situations can be equally chaotic, not being able to know who the natural helpers are, but also not being able to bring together the good that is out there. And so early on in that project, Dr. Friedman held a kind of a town hall meeting, and she was interested in bringing a fresh fruits and vegetable market next to a federally qualified health center. And so the doctors at the federally qualified health center wrote prescriptions for the farmers market that was right next door. And so we had to engage the farmers. And farmers in Orangeburg had just been excluded. They didn't have a voice. They didn't have representation. They were pretty well dominated by industry that they weren't part of. And so just even bringing them to the table and listening to them and giving them a chance to voice really had a sort of an empowering effect, I would say. We had a number of them then sign up to be vendors. And so I think it's finding those natural helpers, and that it's also figuring out in situations where there is that disorganization, how you can give people that voice and bring them together to have that. And that may start out being one-on-one, sometimes it may be in groups, and it's certainly not going to be without frustration in those instances or in very well-resourced instances. But it's a commitment, and I think it pays off in the end.
Any questions? I know we're just about a minute or two over. Well, please come up and talk to
Thanks,
Dr.
y'all.
Brandt
I
about
appreciate
your
it.
work.
Thank you.